Uh, I'm Salah Abusnana. I'm professor of the endocrinology, currently practicing in University Hospital Sharjah and University of Sharjah, directing the Center for Diabetes, and I'm the director of the master program and PhD program at University of Sharjah.
My name's Kaushik Ray. I'm Professor of Public Health and a consultant cardiologist at Imperial College London in the UK.
Professor Ray, nice to have you with us in this big event in the Middle East, the Emirate Diabetes and Endocrine Society meeting. And we're having the chance to get as much as we can when it comes to the lipid knowledge for our audience. So I might start by asking you, recently, what's the most recent evidence when it comes to the lipid management, which has changed our strategy?
So I think we had 2025, the ESC EAS update to the 2019 dyslipidemia guidelines, and there 12 trials and meta-analyses, new evidence about how we should actually practice management of cardiovascular risk and manage lipids was actually made evident. And the clear take-home message is, first, early use of combination therapies in terms of patients who have higher cardiovascular risk. The goals have not changed from 2019, and if you assess risk, you will manage LDL lowering and reduction appropriately, and using combinations of treatments that have been shown in clinical trials to reduce cardiovascular events. So that was the clear message.
Great. We're talking about individualization these days in most of the guidelines. So how should the lipid target be individualized?
So that starts with risk assessment. And we basically break people down into those with established cardiovascular disease. They have very high risk, so their LDL target is less than 55. For every other group of individuals, you either have to use a global risk calculator like SCORE2 in younger individuals, those 70 and above using the SCORE2 older patients calculator, but there's also high risk conditions like individuals with diabetes, for example, with microvascular disease. They're also very high risk, even in the absence of ASCVD. And familial hypercholesterolemia patients are classified as at least high risk. If they have individual risk factors in addition to that, but no prior cardiovascular disease, they're very high risk. And as I said, all ASCVD patients are classified as very high risk. Now, the goals are 55 for very high risk. They're less than 70 for high risk. For moderate risk, this is 100. For low risk individuals, i.e. everybody else should have an LDL below 130. And if you've got progression of disease, multivascular beds involved, then the goal is now 40 milligrams per deciliter.
So those risk stratification are a fundamental step.
Absolutely. That's always starts with that.
Great. Are there any role do non-LDL markers play in the management of hyperlipidemia?
Yeah. So the first goal that we have is LDL cholesterol. Why? Because if you do a lipid panel and you look at non-HDL includes three particles basically. These are the ApoB containing lipoproteins. And in normal individuals whose triglyceride levels in particular are not elevated, virtually all of the non-HDL is due to LDL cholesterol, and virtually all of the ApoB is due to LDL particles. However, in individuals where triglycerides are high, they will have high levels of VLDL particles. These carry triglycerides and alongside them cholesterol or remnant cholesterol. So in those individuals, the secondary targets are non-HDL and ApoB. Why? If you only manage the LDL portion, you will see other residual ApoB containing particles and residual risk in those individuals. And if you don't look at the non-HDL or the ApoB, you'll undertreat those patients. And the way that you're going to manage those individuals is you're going to focus on non-HDL and ApoB reduction, which actually means using more intensive treatments. So a second agent, for example, might be an oral agent or an injectable therapy, which will drive down both LDL, non-HDL and ApoB.
Right. What about the residual risk? How we can address it?
So the residual risk patients, and this is really where this nuance is coming in. So residual risk, the first thing to remember is that if you start primary prevention late or secondary prevention late, or you don't manage conventional risk factors aggressively, there will be risk related to uncontrolled risk factors or starting late. If you take away that portion, there are individuals who will have still a higher event rate. That's what we mean by that. Who are they? These are going to be people, for example, who have a high lipoprotein A, or who have a high triglyceride, or a low HDL, or chronic kidney disease, or diabetes, or potentially inflammation. You have to manage conventional risk factors much, much more aggressively. In the patient with diabetes, you want to manage diabetes and glucose using evidence-based treatments that change outcomes like GLP-1, SGLT2 inhibitors. You want better blood pressure control, not necessarily 130, 120 in those individuals. So we don't have treatments that make chronic kidney disease go away, but you have to manage other conventional risk factors more aggressively. In the future, we might have anti-inflammatory therapies. In the future, we may have LPA-lowering therapies.
Yeah, great. So that answer brings me to the question, what's the optimal level for or what's the target, basically, or the lower is better?
Yeah.
And
well, I think essentially the guidelines tell you that every human being that you see should at least have an LDL below 130. That's the starting point in all individuals. And then how low you go depends upon your probability of having events. So if you're somebody who's extreme risk because you've already got disease in more than one territory, or you've been on lipid-lowering treatments, but you've still got progression, that needs to be 40. There's no safety issue with a very low LDL. You don't get hemorrhagic strokes. You don't get CK abnormalities. You don't get liver function abnormalities. So don't be frightened if you see LDL cholesterols of 5 or 10 milligrams per deciliter in those individuals, because your body cells make all the LDL they need. There's a difference between what's circulating in blood. And a healthy, normal baby is born with an LDL of about 25 to 30 milligrams per deciliter, and we see normal brain growth, normal hormonal function. So treat to risk, but importantly also consider early treatment, early primary prevention.
And single versus combination therapy.
Yep. So I think that's really important now, because we've had 5 different ways of lowering LDL that have all shown reductions in cardiovascular events. That means nature doesn't care how you lower LDL. If I change LDL by 38 milligrams per deciliter, 1 millimole, with approach A, B, C, or D, they will all give me roughly 22% risk reduction. 2 millimoles, 40% risk reduction, 76 mg per deciliter. So what we know is those lower targets are not achievable with statin monotherapy. You can't get to 55 in about 80% of patients if you only use statins. So depending upon the target that you're aiming for, you're going to have to use more combination therapy. So it's not just about the LDL, it's about the risk-based goals, which means that essentially 80% of patients where you're aiming for 55, you're going to have to use 2 or 3 drugs or 1 oral agent and an injectable. If you're aiming for 70, you can probably get 50 to 60% of your patients to goal with 2 oral agents, but the remainder will need a 3rd oral agent or an injectable. So we've used that and use that early.
Statin intolerance, is it common? And what we should do about it?
So statin, it's a different question. So if you ask the question, do statins cause muscle aches? Yes, maybe in about 5%. Do they cause CK elevations? In about 3 per 10,000 per year. Do they cause hepatitis? No. That's about 1 per 100,000 per year. And today there was a meta-analysis, the largest safety data reported in the Lancet, which basically showed of the 86 things in the packets with statins, only 4 are different in blinded trials of statins versus placebo, i.e. causal. And the absolute difference, numbers need to harm, are really trivial. So we as doctors have a duty of care to explain risk and benefits to our patients and explain that if somebody gets muscle problems, which is the commonest thing, then we can reduce the dose. We can use a different statin. We can use alternate days twice a week. But we also have non-statin medications that we can add in. Bempedoic acid, ezetimibe, injectable PCSK9 directed therapies as well. But statins are still the foundation.
Great. When it comes to adherence to statin, anything we can do to improve that?
Yeah, I think that because of the use of combination therapies, my routine practice now is not necessarily to use the very highest doses, so use 1 dose down. The reason is when you double the dose of a statin, you only get 6% further lowering. But if I add in an oral agent like ezetimibe, bempedoic acid, or an injectable, I'm getting 20, 25%, 50, 60% further lowering. I think you explain to the patient that we can, if you get muscle aches are more common at the highest doses. And only a small proportion, 5% to 7%, might experience that. But we're going to use 1 dose down. But we might need combinations of treatments. And in this region in particular, there are many fixed dose combinations, so you reduce pill burden. So you can say to patients, you could stop medications whenever you like, but you take the consequences of that. And you've got to explain to the patient what the benefit is, because they don't feel any better when the LDL goes down. And they read all of these things that go to YouTube, which is often opinion-based nonsense. So that's really important. And you say, if you run into problems, I am here. I can help you. There are things that we can do. And it's that education that I think is really important.
And what's the strong message we have to send to the patient regarding the long-term lipid control?
So we know that the longer you treat, it's like saving for your pension. The longer you treat, the earlier you treat, the earlier you bring cholesterol down, it gives you compound interest, like interest in a bank account, saving for your pension. The earlier you start, the longer you go, the more money you have when you retire. So in this case, that money is the number of life years you're going to get free from cardiovascular disease, free from heart attacks, free from strokes, and essentially prolonging life the longer you go.
I chaired your session this morning when you talked about the guidelines, nicely illustrated, and the update from 25. Do we take in consideration the population different when we have the guidelines?
Yep. So I think that the one thing that I would say is we treat people the same way. So the best example of this is the Indian guidelines, for example, the Lipid Association of India or the Cardiological Society of India. What they said was, we are genetically more vulnerable. If we are genetically vulnerable, we should stop talking about, like, we're the world champions of heart disease and it occurs 10 years earlier. That's nothing to be proud of. So if heart disease starts 10 years earlier in the MENA region, you have to start prevention 10, 15 years earlier. You have to, when somebody has heart disease, you're more vulnerable. You have to treat more aggressively.
Yeah, great. At the end, I would like to thank you very much, Professor Ray, for this interview, and hopefully that will benefit lots of healthcare professionals and patients as well. Thank you very much.
Thank you.
Thank you.